Hello, everyone, and welcome to another episode of the Happy Doc. So for this episode, you are going to hear from Dr. Wendy Dean, and I actually had her on episode 100 of the podcast, and you'll hear all about me referencing that in the recording of this episode. I just want to say that, when I do this show, there's a lot of sort of theoretical conversation or talking about ways we could improve our health or improve our well-being. Well, that's all great, but with COVID-19 and what's going on in the world and this pandemic, it's just exponentially more important. And so I'm absolutely excited for you guys to listen to this conversation because we really dig into kind of the psychological, the material, and the reality of what COVID-19 is doing in the front lines, and we have a nice conversation around that. Additionally, Dr. Wendy Dean and her team at fixmoralinjury.org have developed a toolkit for clinicians and leaders in hospital systems and who are actively practicing in the front lines to assess, if they've incurred moral injury, and you guys will hear what that means in the conversation, and providing recommendations of ways to really help these individuals. So for clinicians and leadership staff to use this tool. So I'm not going to get too deep into it, but just a brief introduction. Dr. Wendy Dean practiced as an emergency room physician and a psychiatrist. She also managed medical research funding for the U.S. Army and was an executive in a large nonprofit in Washington, D.C. before turning her attention to moral injury. So you guys are going to hear all about that in this podcast episode of The Happy Doc. Please take a listen. It's an important conversation. And if you enjoy the episode, please share this one with a friend. And if you want access to the clinical toolkit, please go to fixmoralinjury.org. And there is a COVID-19 resources tab. Additionally, I'll be leaving the link to the website in the show notes. Enjoy the episode. I'm always excited for my guests to be on the show, and I have Wendy Dean with us today. I had her before, and I was looking at the date. The date was December 5th, 2018. We had an episode all about moral injury. And at that time, there were many articles coming out about the idea of moral injury and looking at that kind of concept as opposed to burnout. So I think Wendy will start to get right into it. Wendy, how are you doing?
I'm well, thanks.
Amazing.
Pandemic.
Yeah. For a pandemic. I mean, this is COVID-19 times, and it's a very strange world right now. So let's hop right into a little bit of your background first of all, and then we'll kind of talk about moral injury and progress from there.
Sure. So my background is I trained for a few years as a surgeon, and then switched to psychiatry. I practiced in various different settings, from academic to private practice. Then I shifted about a decade ago to working in research management oversight. And about 6 months ago, a little bit less than 6 months ago, I transitioned to working 100% on moral injury and trying to address clinician distress.
Okay. All right. And so for those who aren't familiar, I think in general, everyone is familiar with burnout and the terminology there, or has experienced some form of burnout, especially in the health professional space. What is moral injury?
So the definition of moral injury that we tend to use is that it is perpetrating, bearing witness to, or failing to prevent an act that transgress deeply held moral beliefs. And in healthcare, those deeply held moral beliefs are the oaths that we take to put our patients first. So when we're faced with a situation where we have to choose something other than our patient as a priority, that's where we start to experience those moral insults that eventually add up to a moral injury. And so it can be anything from having to take care of the electronic medical record rather than being able to engage fully with your patient. It can be the fact that maybe as an oncologist, you know that your patient needs a particular medication, but the insurance company doesn't authorize that medication. And so you know that your patient is not going to get it or has to go through trials of other medications that aren't going to be as effective in order to get the approval that they need.
Right.
So anytime that you can't get your patient the care that they need or is available, that's really where moral injury comes in.
Yeah. So, I mean, almost, just to make it really simple, you're a human and you want to help a human life. And anytime there is that moment where we realize that we can't hand them the tools or we can't provide for them in the way that they really should or need to get that treatment, we feel that moral insult and injury, as you discussed.
Correct. Especially if we know that what they need is available, just not to them.
Right. And so we had a long discussion about this actually with another physician, Simon Talbot, in episode 100. So we won't go through a full discourse about moral injury in terms of the overall healthcare system. Now times have changed. We have COVID-19 specifically now. And so we've added another aggressive variable into the mix. And now that adds another layer in which this moral injury and insult is going to occur for us, right? So before we get into all of that, I actually have a question I wanted to ask you before that, which is what caused you to transition fully to the topic of moral injury?
So when Dr. Talbot and I published that paper, I was working as the senior vice president of program operations for a very large nonprofit that supports military medical research. And so that was an 80-hour-a-week job. And after the publication of that article, we had no idea really how much that those thoughts and those ideas would resonate. And so what ended up happening was I was doing that senior vice president job 80 hours a week. And then I was doing the moral injury job at least 20 hours a week. And we kept sort of waiting for the cycle to die down and waiting for interest to kind of trail off.
Yeah.
And really it continues to grow. And so it became very clear last fall that somebody needed to pay attention to that full time.
Yeah.
So that's why I transitioned.
Yeah, no, I mean, and it's a very powerful topic. And I think, physicians on the front lines, myself included as a resident, we're often just so busy working all the time that there's no one really defending the heart and the spirit and the humanness of what we're doing. And I think the definition you provide with moral injury is a very powerful one because we feel that every day. Every day there is a prior auth that gets denied. Every day there's a medication I can't give to someone. Every day there's a moment where in the back of my mind, I know there's a resource out there, but because of the patient's socioeconomic status or what have you, they're just not going to be able to have that level of care that's probably actually best suited for them. And so, obviously there's many of those examples. Now we throw in COVID-19 into the mix. So I know that you also recently put out another article I saw featured on Medscape as well. But can you tell us more about your thinking around, what's going on right now? So
I think the moral injury that 50 or 60% of the healthcare worker population was experiencing before has morphed in that it has become not so much about, can I get the insurance company to agree to this? Am I paying attention to the EMR instead of my patient? What it is instead is, do we have enough resources for the number of patients that are going to come through my door? Are we prepared with space, stuff, and staff, right? Do we have enough room to put them? Do we have enough ventilators? Do we have enough tubing? Do we have enough medications for them? And then do we have the staff to take care of them now? And will we have the staff to take care of them in 2 or 3 or 4 weeks? And also layered on top of that is, how do I keep myself safe? And how am I going to face that impossible, the absolutely impossible choice of knowing that I may not have PPE, personal protective equipment, that's adequate to this virus, to combat the virus or protect me from the virus. And there's a patient in need in front of me. So in the Ebola crisis, it was very clear. There's no emergency in a pandemic, right? There's no emergency in an epidemic. You take the 10 minutes to don your PPE with your observer before you go into aid. That is an exquisitely difficult decision for a healthcare worker to make. With the Ebola crisis, they had the PPE. They just had to choose to use it. In this case, we're being faced with the question of, what do you do if you don't have it? And I think that's a point at which the real crux of the moral injury is going to become. There's going to be a long tail on that, and it is going to take a very long time to resolve those questions. In addition to the questions of, who do I choose to put on a ventilator? Even if there are clear guidelines, even if there's a clear scoring system, even if the decision has mostly been taken out of my hands, I am still the one who is proximate to that decision.
Mm-hmm. Yeah.
So, I think it's magnified. And the challenge with a lot of this is we're looking at it and saying, would that we had listened to those who were saying we should prepare.
Yeah.
So there are a lot of layers here, I think.
There are a lot of layers. And, as I'm hearing this, the concept of almost material management and and human management, it reminds me of war, mm-hmm. right? Because if you're, for example, in a foreign country or foreign land, or you're battling, you have to choose what troops are going to what location. How are we going to defend this area? What weapons do we have? What materials do we have for protection? There's an assault, there's an offense that's coming, there's a battle. And you mentioned your military background, right? But the truth is right now is there is a war, right? I mean, the war in this case is an unseen, invisible virus that is killing approximately 1% of the population. Actually 3% of the population, if not more, right? Depending on the group. And it's dangerous, and we do not know how to deal with these ethical and moral issues that you bring up. So with all that being said, again, there's so many areas that we could take this conversation. And as you were talking, one thing that, sprung up in my mind is these situations are already being dealt with. I've heard and seen multiple stories of physicians that are making the choice to go into battle, so to speak, without PPE, and they're choosing to put their life on the line.
Right. And we know that it happened in Italy as well. And I think everyone has to make that choice for themselves, but I would, the thing that we have to think about is if we make that choice to go in unprotected and then we become a victim, we're not only not able to take care of patients for the foreseeable future, we're also then using healthcare resources. Right. And so we may be using a ventilator that could go to somebody else if we had protected ourselves. Now, I also don't want to get into the catchy bits of blaming healthcare providers for the choices that they make. But I also, it just brings to light how difficult these decisions are in the context of what weren't our choices of preparation.
Right.
So I thought one of the places that you were going to go with this was to say, in battle, one of the places that you can lose the war is in your logistics chain. And really, I think one of the huge lessons learned in this is that hospitals ignore their logistics chain, their supply chain at their peril. Mm-hmm. And it's also one of the challenges where we have cut our staff, our space, our supplies to the bone in order to meet some, revenue targets that are necessary to stay alive, but maybe we need to renegotiate some of those terms coming out of this, being on the other side of it. And to say, those supply chains, it's important to have multiple sources. It's important for us to not have just enough for a week. We need to be able to prepare on a much longer horizon. Because I think COVID is going to be partly about, were we looking on a long enough horizon? And did we plan far enough in advance?
Right.
Was it sufficient to cancel elective surgery a week before the first patients started testing positive and coming into the hospital? Or at the time when the first patient was identified in your hospital's community, was that sufficient?
Yeah. It's, there's so much I can talk about with this. The idea of the supply chain, the idea of preparedness, the one thing that comes up, and you brought it up, but I'll say it very directly, is there is a conflict, right, between hospital systems wanting to also be able to make money. Yeah. So there's the business of medicine. And then on the other side, there's the human portion of medicine. And you bring up a really great point, which is, how many resources do we actually need? Every business does this. How many resources do we actually need? Let's approximate, we'll get just enough resources to essentially protect finances and, get a strong bottom line. But then when we have a ridiculous and almost unforeseen pandemic, where we haven't thought about the long tail possibility that something else is going to happen, we don't have those supplies ready. And then in fact, long term, as we all know now, trillions and trillions of dollars are being lost instead of having that preparedness. So it brings up an important question. How much do we prepare for the worst? And how much do we also have to protect the business? And in healthcare, that's a very tough situation because humans aren't dollars. I mean, we can approximate how much a human can make, but a human being's life does not have a dollar amount. So how do we deal with that?
Right. So I think at base, the conflict that you're describing is a conflict in what our goals are. So the business of medicine has the appropriate goal of keeping the organization afloat, keeping it alive, and also of making a reasonable return. Now, for a nonprofit, that has a bit of a different spin, although they still need to bring in revenue. Nonprofit doesn't mean they don't make money. It just means they roll it back in.
Right.
So I think one of the things that we need to talk about as a society coming out of this is how do we renegotiate what our expectations are for healthcare? So, kind of renegotiating the contract with healthcare, and where we have the business of healthcare that's trying to, their real goal is revenue, right? So that's their focus. For physicians, the goal, physicians and other clinicians, the goal is patient outcomes,
right? Having
the patients do well, taking care of the health of the community. But when you have those two opposing goals, you're never going to get rid of moral injury until you have people aligned in the same direction.
Right.
Because moral injury really comes at the crossroads of those two things. And And I think now isn't probably the time to renegotiate that, but
of course,
but we can start to agree that what's important are the people who are taking care of the patients, the outcomes of the patients, the other workers who are supporting the people taking care of the patients. If we don't have all of that structure, you take out any one of those necessary entities, and things start to fall apart pretty quickly. What I worry about is that oftentimes clinicians are looked at as kind of expendable or replaceable. But I think I'm worried that we're going to find out how very untrue that is going forward. It takes a decade to train a physician.
Yeah.
And if we lose a substantial number of them because we didn't protect them, that is going to be a huge reckoning for the healthcare system.
Yeah, definitely. And in medicine, as with other specialties and other fields, there's certain things you learn through experience that is impossible to learn any other way. There's just certain things that happen on a call shift at 3 a.m. where someone just starts to crash and you have no idea why, that whether you like it or not, in that experience, you learn something about blood pressure, you learn something about sepsis, you learn something about, a million things that you won't recognize any other way. And those years of experience, as you mentioned, are irreplaceable. And it reminds me of those almost ethical riddles and moral dilemmas that you hear about, where a car is about to hit a crowd of people and you can only grab one. Like, do you save the doctor? Do you save the child genius? Do you save the, and you can paint the scenario how you want. It is a tough ethical and moral question to say, do I stay out because in the long run, if I stay out and quarantine myself and come back with the right PPE, I'll be able to save hundreds of lives? Or do I go in because I can save hundreds of lives now, and I'll take the chance because I'm a little bit younger, or I'm generally healthy, or even if you're even if you're in the demographic that could get possibly sick, do you still take the chance?
Well, so I think one thing about that is there's no longer a demographic that is at risk. I think it's very clear from what we're seeing with patients that it's every age.
Yeah.
Less children, but once you hit your 20s, you're at risk. So, that's one of the issues. But I think the thing that is really hard about this is absolutely we are having to pivot, like almost on a dime, just absolutely turn 180 degrees from a society that says in our healthcare, it is about the individual, and we are going to put all of our resources behind taking care of that individual. And rationing is anathema to our system of healthcare. And so we don't have practice in it. We don't have thought patterns in it. Mm-hmm. It really goes against kind of every fiber of our being to think about rationing. But in other systems where that is more of a reality on a day-to-day basis, it would still be hard, but it's going to be less of a wrenching change. And it's interesting. I think we so infrequently practice real triage that coming face to face with what it means in reality is exquisitely painful. And I think the other one of the big lessons coming out of this is that those emergency preparedness plans and exercises that every hospital is supposed to be running if they participate in Medicare, they're going to have to actually become meaningful. And I think that conversation about how do we do triage? How do we actually think about triage and think about what those lives are going to look like. Maybe it's not always a train wreck. Maybe it's an airplane crash. Maybe it's, poison gas leak. Maybe it's a nuclear bomb. Maybe it's a pandemic.
Mm-hmm.
But really thinking about how we manage in a constrained environment much more than we ever have had to.
Yeah. And now we're facing it very fast, and we haven't hit the peak of this in the States for sure. That's going to be coming up probably in the next, week, 2 weeks, 3 weeks in terms of this starting to peak even further. Something that I was thinking as you were saying all of that, which I also think is a very difficult part of all of this, again, you mentioned the true triage. Like you said, most people have not actually faced that situation. Now we have that battle here in our own country. But the other thing that comes up with that triage situation is also the emotional trauma and the long-term effects and the mental images. And as you know, of course, when you face any difficult situation of making the decision, and even if technically after reflecting on it, you might say to yourself, I think I did make the right decision here. It might be a situation where there is no right decision and it's a confusing mess. And you've made the decision to save person A or give the PPE to person whoever. But then in your mind, because the mind can see all parts of the situation, your mind says, well, what if I had taken the other route? And that will haunt everyone. And I know, for many health professionals who are listening, we've all faced a situation where we made a decision and second guessed it. And then afterwards, we're not 100% sure if we made the right choice. And this is happening now multiple times a day. And it's going to become exponentially increase where we're having these decisions. I'm concerned about the long-term mental health of these individuals who are truly, as you were mentioning, even with the guidelines or what have you, checklists or some form of decision-making algorithm, I'm still concerned that those individuals are going to have some effect that is going to be extremely detrimental.
Yeah, I think there was even if we had been practicing for a pandemic and practicing the triage and practicing all of that, it might have made the shift easier, more fluid. But there's no way that we would ever be prepared for the decisions that we're going to make. And I can only compare them to what was the 1918 pandemic, or I think that we have not seen this level of distress or this level of morbidity and mortality ever. We've never imagined it. So there are a few people who have probably traveled to natural disasters or have helped out with Ebola. But even there, it was not at the same massive level. And so I think we are going to have a very long tail. And the challenge for the healthcare system is that one of the ways that you manage that is, for example, with the military, when they come back from deployment, because when you look at how physicians are preparing for this and are managing this, some of them are kind of doing like in place deployment. They're leaving their families, mm-hmm. They're setting up apartments, they're not going home in order to protect their families. Mm-hmm. And so when this is over, people are going to need time and space to breathe and to process and to move through what this means and to grieve all of what they've seen and haven't had time to grieve in the process of it. But the challenge is going to be that the healthcare system is going to have a massive backlog of deferred maintenance, what you can think of as deferred maintenance with
Right.
people who really need to have the surgery that they've put off, the preventative procedures that they've put off, their wellness screens. And so it's going to be, pandemic goes down and business as usual ramps right back up. And in between, I'm worried they won't have the space to breathe.
Mm-hmm.
And so if there's anything that we can do to help healthcare systems see that a slower ramp up will help everybody, and if we can help the government understand that supporting a slower ramp up is going to be helpful, that would be great.
Yeah, I mean, it sounds great in theory. It's interesting because as you're speaking, it reminds me of the disconnect that the general public has with, we have some experience, but for individuals have no scope of what's happening. A lot of people are, again, truly disconnected. And especially with 2020, you can hang out in the house, you can be quarantined, you're watching Netflix, what have you. So you have your entertainment, but you're not in the hospital and you don't see the cases that are coming up and you don't understand these decisions that are happening. And so there's one part of the population, the physicians, the health professionals who couldn't use the slowdown. There's the other 98% who are ready to break out of their homes, right?
Right.
And especially now after being quarantined for quite some time, that side is definitely ramping up. For me personally, I have a lot of friends who are in the entrepreneur world. I have a lot of people who are, I don't get this. I don't understand this. Why are we still in our homes? And individuals who are trying to build their lives. And, as of course, with the United States, I think this is one of the issues with the United States is we highly love our independence, but that independence is really hurting us when it comes to things like quarantining and doing what we need to do to protect the population.
Right.
So it's there's a lot of conflict with slowing things down. Right.
Agreed. And I'm not, I wasn't saying that we need to I wasn't saying that we need to not break out of quarantine slowly, although we might need to do that, out of quarantine slowly and then go back in again. But what I'm saying is the healthcare world is going to need a little bit of, it's going to need a minute to recover.
Yeah.
And I'm worried that if we don't allow that and we don't acknowledge that need to regroup, kind of retool, that we're going to do a lot of damage to an entire cohort of clinicians.
Yeah. Yes, definitely. And it's bringing up, this situation is an insane, rare moment, right? This is not a typical thing that we see. And as such, the normal or standard of thinking and the standard of the legal situations, the standards of our ethics, the standards of our morality in this situation are different. They need to be. Now, the legal situation is definitely loosened up, right? So, for example, insurance is paying for telehealth visits. We would never normally see that. There are definitely people that now we're being able to effectively bill even if there is no physical exam and those types of things. So something else, and we're kind of, talking about that there needs to be some more flexibility in our thinking around this time, because this is not normal. It's also an incredible lesson, as you're mentioning earlier. How do we think about insane situations that are not normal, but we have to come up with, guidelines, standards. And I know it's, you and I are having this conversation here, but this is going to take a world of people to understand and break down and come up with what do we do in these situations.
Right.
So moral injury, when it comes to COVID-19, clearly, I mean, I was going to ask this as a question, but moral injury wise, this is just exponentially ramping up the amount of moral injury moments. Is there a term you use for the specific moment, I guess?
So, the way we look at it is that there's kind of a progression, right? There's moral distress where you're sort of uncomfortable with something.
Mm-hmm.
There's an incident where you recognize that you're caught in a double bind and that you have to choose something other than your patient. But we all feel like if any one of those incidents we could probably resolve and manage over time. But it's when those incidents or those insults happen on a regular basis with frequency, multiple times a day, week, year, month, and when those insults come together, they kind of amass into the moral injury. And when you get to the point of moral injury, it's when you start to think to yourself every now and then, can I really keep thinking of myself the way I would like to as a moral being, as a physician who's doing well, who's doing good for their patients and doing well by their patients? Can I continue to think of myself that way if I continue to work in a system that prevents me from getting patients what they need?
Yeah. And then now, if you think about just, if we were to make the average sum, right, of the global values of a typical health professional, right? Of course, every country is different, every culture is different. But if you just amassed it and we had a general set of global values, I want to heal the person, I want to make sure that I can provide for them, I want to make sure that I stay safe, all these general values that would make sense. The global moral injury is at an all-time high. And it's, again, you and I don't have the answers here. It's not something, this is all discussion. This is more philosophical. If anything, we should probably have a philosopher with us as well. But it's something that, is definitely necessary to have a discussion around.
Right. And I think one of the important things to recognize and what we found in the last 2 years is that giving people the language that to express what they're experiencing can be powerful in and of itself. So for them to be able to say, this double bind that I find myself in, this place of frustration or anger, it has a name, and I can tie it to the reason why I feel it, and that way they can at least understand the framework of what they're feeling, and then have handles to grab onto to try to change it.
Yeah. I mean, the language is the first part. You need to be able to define what you're feeling, right, before then there can be some form of action or even just support that can be provided.
Right.
So I guess that would be the follow-up question here is, we're going to be dealing with this time right now. It is what it is, for better or for worse. There's going to be a lot of moral insults, a lot of double binds, and ultimately the injury. How do we, as a group and as a population, heal and limit the damage or the injury that occurs?
Yeah. So I think there are two ways that we can approach this, or that we need to approach it. We need to approach it as individuals, not because we can fix the moral injury piece of it, but because we're a high performance machine asked to be working at or above what our normal capacity is. Well, and in fact, for a lot of people, it will be well above their normal capacity, both physical and their psychological, what their normal baseline is. So taking care of yourself is going to be critically important. Making sure that you stay grounded with the people that are dearest to you, that you stay in contact with them, ask for support when you need it, that you find a team at work who are supportive and can can have each other's backs a bit in this. If you kind of put your hand up and say, I need to tap out for 10 minutes. I just need to go get some headspace. Somebody can say, yep, gotcha. You go. Where you can come together at the end of the day and kind of process things. Sometimes reflection rounds at the end of the day, 10 minutes, 15 minutes for the healthcare team can be really useful to kind of just make, even if it's just to speak what everybody else is feeling so that you know that you're not alone, can be critically important. Make sure that you eat, make sure that you hydrate, make sure that you sleep. I know that those are really basic things, but a lot of people are having trouble sleeping right now. And when you're on shift in PPE, it's very hard to eat. It's very hard to drink. So, just getting to the very lowest level of Maslow's hierarchy of needs, food, water, shelter. Those are incredibly important. The next is safety. Wherever we can help each other stay safe, do that. And also, when you are out of work, be out of work, right? Find ways to recharge. Find ways to get into the other side of your brain and start creating something. Even if it's not going to be the Mona Lisa, draw something, paint something, sculpt, cook, garden. Whatever outlet you find gets you out of your head a little bit and away from COVID for a minute is critical. Yeah. The other side of this, I think, that we need to do, so, take care of yourself, take care of your community, and then kind of try to get yourself escape in place, right? On the other side of this are the leadership pieces, where we really need to ask our leadership if they're really stepping up to stay there, because that's very helpful to us. If they aren't quite where we would like them to be, to encourage them, to have, to hold hope for them that they can get there. And I think, again, this is a place where take care of your staff, take care of your community, communicate with absolute transparency. What does the illness in the community look like? How many cases have there been? How many are in your hospital? How many patients are ventilated? How many ICU beds do you have? How many are available? How many patients have gotten better? Right? Because that's going to be really critical. We have got to celebrate those small wins. And then what's your staffing? What are the staffing levels at? So that people understand what the battle space looks like, right? So do that. Also, I would really beg them to do their level best to not tell people at this time that any portion of their security is in threat. So, please don't tell people that they're going to not get their full salary, that they're not going to have their retirement benefits, that, there are places that are still negotiating contracts at this point, which may be important. But if there's any way to freeze those or, at least temporize a postponement, because asking people to risk their lives and then telling them that they can't, they also have to think about their financial security, that's not a good look for anyone.
Yeah. I mean, you brought up some fantastic points. It was a great list of things that we should all be thinking about. The list you mentioned are great things to think about always, but even more important when the stress level is incredibly high. I loved what you said about, basic things being basic: sleep, water, food, emotional support. These are things we always need, and especially now. And something I would add to the great list you provided is there's a lot of people I feel that feel hopeless being in quarantine who are family members. So I would say that and family members, but like not just immediate family, I'm talking about cousins, uncles, any moment where there is an opportunity, if you feel helpless, to text, send an email to those individuals who are in the front lines, nurses, environmental staff, any individual that's part of the healthcare system. Doesn't have to be just strictly physicians by any means.
Yep.
There is that opportunity to say, we are still connected, even though we are not literally next to each other. I'm thinking of you. Right. And I'll tell you, when you're in a dark place, that email, that text really does go a very long way. So I think that's something else we can do to empower individuals who, aren't, in the battle, so to speak.
Oh, absolutely. I mean, I think there's a whole other set of things that people out in the community can do, right?
Yeah.
I would love for leaders in hospital systems to be asking their community to donate to, or to sponsor meals for the ICU team or for the ER team. I bet there are neighborhoods that would be glad to do that, right? Asking people to sew their own masks that they can send out in the community, not to the healthcare workers, but to everybody in the community who should be masked up by now. People want something to do. People in the community want something to do. And so if we can ask them to do those kinds of things, I mean, I love NNTR, right? No need to reply in front of your text, just thinking about you, sending something up on Twitter, sending something up on Facebook, because, not all the physicians, but a surprising number are on there. And if you send out a hashtag #MedTwitter with "thank you for what you do," that takes you 2 seconds and it can make somebody's day.
Yeah.
Right?
I mean, I love that. I love that. And there's so many things, like, there's a much more exhaustive list I'm sure we could come up with of the community efforts. It's an interesting time. It's a difficult time. We've talked, I'm sure we could talk much more about the different pieces of, moral injury and where the sources of that could be. But I think I'm just going to open it up to you. Was there anything in this conversation, or was there anything you felt that we didn't touch on that you really wanted to let our audience know today?
So there are two things. One is that I think all of us are not giving ourselves enough credit for the resilience that we're displaying in being able to adapt very quickly to an entirely new world. Right? Just the fact that everybody is now teleworking or cyberschooling or doing both simultaneously is really impressive. I mean, that level of adaptability, I think, is just remarkable. And it shows our human ability to adapt to change very quickly. So kudos. The other is that we are trying to develop a toolkit that we're going to try to pop up on fixmoralinjury.org that will kind of run through those lists. We're going to have one for healthcare providers and one for leadership, just as reminders. Here are the things that you can do. We're also going to try to have a brief screener of, what level of moral injury are you experiencing at this point?
Mm-hmm, mm-hmm. Yeah, those resources would be great. I mean, I know we're kind of talking about it long form, but if you had a one-sheeter or whatever it is, sounds
in the works.
Yeah, I mean, I didn't even think about that, but I'm glad that you're on that, because a one-sheeter of the things to think about through this process, just trying to keep your head above water while you're facing this challenge, I think is going to be incredibly helpful. And I'm glad that you're making that resource.
Yes.
So how do people find you?
So I am on Twitter, Dean MD. I am. You can find our website at fixmoralinjury.org. And there you can also contact us at info@moralinjury.healthcare.
Amazing. I mean, look, you have truly now focused in on moral injury. I'm glad you're doing it. It's something that is rampant in the healthcare profession, definitely, and now it's just even more intense with everything going on with COVID-19. I sincerely appreciate your time. That was not an exhaustive conversation at all. There's so much more to talk about, but I want to thank you for being on the Happy Doc.
Yeah, thanks for the invitation. It's great to see you again. I'm sorry it's under these circumstances, but and I'm happy to chat anytime.
We should probably schedule it during a happier time, shouldn't we?
Yes.
All right. Well, thanks for being on.
Thank you so much.
All right. And there's the episode for today with Dr. Wendy Dean. It was a great conversation, extremely important. And as we had referenced before, you can check out the clinical toolkit that her team has created on fixmoralinjury.org. We've also left a link in the show notes. Have a great day. And if you love that episode, please leave a 5-star review on iTunes. It's one of the best ways to support us. And please share this episode with a friend in need. Have a great day, and I'll see you guys on the next episode of The Happy Doc.